Okay. I am going to open Health and Human Services, and we are going to recess until, let's say, 9:15. Hopefully, everyone will be here at 9:15. Thank you.
The company last night.
And Goodness gracious. Okay, I'm going to open the hearing on Health and Human Services. Do I hear a motion to go into exec?
So moved.
I'll second. All those in favor of exec, say aye.
Aye.
Opposed? All right, we are going to exec the last Senate bill we have, which is Senate Bill 558. Oh, here it is. And
You need a motion to pass?
I do,
I'll motion to pass. Second.
okay. Senator Avar ought to pass and Senator Whitley seconds. And we have a committee, or we have an amendment. Would you like to come up and discuss it, or?
Is that this one or hers?
No, not that one.
No?
No. Welcome.
Thank you. So, as I think the members of this committee know, Senate Bill 558 has been the subject of much discussion. So I would like to thank everyone that's been involved. We've had several Zoom calls with 17 people and other multiple split screens. We remain in very active discussion to try and find the right language to accommodate everyone's concerns. We're working actively with the insurance department, the providers, the advocates, and we hope to have agreement for you, as soon as next week or before crossover when the bill is in finance. So for now, we've brought you a study committee. We want to keep the bill alive while we continue to work on the language. We appreciate your support, and I think there's just one small change. Which my copy doesn't show. Do you have the highlighted version? Here. I just ended up without the highlighted version. Thank you so much.
We don't have this.
Okay. That's this one.
However, we're going to add some language.
So,
Do I move an amendment before?
Senator, are we gonna move one of the official amendments with a committee amendment?
Yep. So what I'd ask you to move is Amendment 1279S, which was released to you, I believe, yesterday.
Okay, I moved.
Second.
And then if you would be so kind, I would ask for a committee amendment.
Sorry,
yeah.
it's 1279S.
Yeah.
Well, yeah, I moved 1279S.
Okay.
Yeah.
And you seconded.
Yeah.
Yeah.
Okay. Yep.
Okay, we're all here. If you would be so kind, there's an amendment in the duties that I would ask you make as a committee. So the duty reads,
What line?
19 and
Oh,
20.
19.
Yeah.
yep. So in the duties, we want it to read, the committee shall study commercial insurance coverage of fertility treatments, comma, including for same-sex couples, comma, and employee protections while receiving fertility treatments.
I'll move that committee amendment.
Hold on. Can we go, comma, including for same-sex
Couples. Yep.
And that's it?
That's the committee amendment I'm
Okay.
asking for, yes.
All right. Senator Whitley moves the committee amendment to include, include for same-sex couples. Okay. Anything else?
That is it. We hope to bring you something of much more substance with more information very soon.
Okay.
Thank you.
All right. So the motion is the committee amendment. All those in favor of the committee amendment, say aye.
Aye.
Opposed? Okay. Do I hear a motion of ought to pass as amended?
Second.
Okay. All those in favor of ought to pass as amended, say aye.
Aye.
Opposed? Consent?
Sure.
Okay. Senator Avar moves consent. Senator Bradley seconds. All those in favor of consent, say aye.
Aye.
Opposed? Okay.
So before Senator Perkins' quote goes, I just want to say, first of all, thank you not only to yourself, but to everybody that you're working on to try to pull this together. There's been a lot of support for it. And there are, I think, several different ways procedurally, if you have an agreement, which hopefully everybody is continuing to work toward, that the Senate will be able to accommodate that. And we discussed that. I just wanted to make sure that everybody in the audience knows that. So that's all.
Thank you, Senator Bradley.
Motion to move out of exec.
Who's going to take Senate Bill 555 out?
I can take it.
Senator Avard moved out of exec. I'll second. All those in favor say aye.
Aye.
Opposed? And we are actually in recess till 9:30, right? Oh, we're right on time then. Okay.
What does that mean?
Bye, Kate. All right, so I will start the hearing on House Bill 1042 and invite the prime sponsor, Gary Merchant, Representative Gary Merchant. Welcome.
What is it?
1042.
Oh, I get the prime sponsor as Rochford. Rochford. Okay.
On his behalf.
Thank you.
Welcome.
Thank you, Chair. Ready to go? I was going for people to get the copies that are circulating around, if we could.
We are good.
We're good. Okay. For the record, my name is Gary Merchant, a state representative representing Sullivan District 6, which is Claremont and Croydon, and also past president of the New Hampshire Water Pharmacy. So this is, and I hate to use the word simple bill, but fundamentally, I was on the board when the bill was created initially to create the Continuous Quality Improvement Program. We had a lot of high hopes for it. We thought it was going to do a lot for the profession to try to minimize, if you will, errors in the marketplace. As you'll see from the Board of Pharmacy in the letter they submitted to the committee on the Health and Human Services side and the House side, they found no evidence, no documented evidence of this bill actually doing what it was intended to do. What they did find is a regulatory burden. We're asking people to do something, sort of make work, and it didn't have or achieve what it was intended to achieve. So the bill basically says, well, if it's not working, why do we have it? And I sat down with Representative Rochford, who's now the president of the board. We worked together and said, what can we do about it? And I said, well, I think we should do is introduce legislation to repeal it, which is a logical thing to do, because if we're asking a profession to do something that has no real benefit to either to the profession or to the patients, we should at that point in time repeal it. So that's what I'm trying to accomplish with the bill. By the way, it came through the House 20-0, and it also went on consent. Went on voice consent, of course, it got through the House. So that's the bill before you. And Representative Rochford wanted me to pass on let you know that he couldn't be here for various reasons, and he's sorry about that, but I'm co-sponsoring it with him, and I said I'd be more than glad to introduce the bill.
Thank you, Representative, and thank you for bringing a bill to get rid of an RSA finally.
We used to have a committee just for that reason years ago.
We did.
Can I join it?
Any questions from the committee? Seeing none. Thank you.
Thank you.
So far, there is no one else to speak on this bill. Is there anyone that is here that would like to speak on it that wasn't given the opportunity? With that, I will close the hearing on House Bill 1042. Committee? You want to go into executive?
Can't, we're not allowed to execute.
Oh, that's right.
Jeff said no.
The Senate President. I forgot.
That's it.
That's right.
To the bus we go.
Our next bill will be heard at 9:30. All right. We're back from recess, and I'm going to open the hearing on House Bill 1171 and invite the introduction, Representative Rung. Welcome.
Thank you very much, Madam Chair. For the record, my name's Rosemary Rung. I represent Hillsborough 12, which is the town of Merrimack. And I've been asked by the prime sponsor, Representative Nancy Murphy, to introduce 1171 on her behalf. Unfortunately, her daughter's having surgery this morning, so that's where she should be. Yeah, and 1171 is a pretty straightforward bill. 5 years ago, the legislature, in its wisdom, passed Senate Bill 85, which was to set up a commission to study environmentally triggered diseases. And it's been a very productive commission, but their work is not over. So 1171 asked the legislature to extend that for another 5 years. I'm not on the Senate Bill 85 Commission, but I was a past chair and a current member of the HB 737 Commission, which studies the health and environmentally impacts of PFAS contamination that began in southern New Hampshire from the St. Gobain facility. And I can say firsthand that we work very cooperatively with the Senate SB 85 Commission. We collaborate on some issues that overlap. I really believe that the Senate 85 Commission is probably as important for the next 5 years as it has been for the last 5 years, addressing a variety of concerns. One is PFAS in the Seacoast area. One is the effects of cyanobacteria toxicity that's growing in our lakes, and it's linked to ALS and other neurological diseases. Lead, mercury poisoning. They're a very comprehensive commission, and I ask that you support this bill. It passed unanimously in the House and through committee. I know there are people here from DHHS that can also speak to the value of the SB 85 Commission, and I would be happy to take any questions. I did hand out testimony from Representative Murphy, and I hope you're also grateful that I didn't read it.
She did send it out.
Okay. Yeah, so I'd be happy to answer any questions you have.
Thank you, Representative. Any questions from the committee? See you none.
Great. Thank you very much.
So we have two other individuals here, but Michelle Roberget from DHHS, neutral, and it doesn't say whether you're speaking or not. Okay, thank you. And Karen Craver from DES, same thing? Okay. Is there anyone here that would like to speak on House Bill 1171 that was not given the opportunity? All right, I will close the hearing on 1171. Thank you.
Thank you. This is an honor. Thank you, Madam Chairman. Thank you, members of the committee. Sorry, I'll get used to this one of these days. Just as a brief introduction, I'm a state representative. I represent Belknap County District 6, but that's not who I'm representing today. I'm a physician. As I think you know, I've been practicing pain medicine, physical medicine rehab for the last 35 years here in Concord at Easter Seals first, and then at Concord Orthopedics. My passion has been advocating for the rights of people in pain throughout that period of time. I humbly represent, in my various roles locally, regionally, and nationally, the 66 million Americans who suffer from chronic pain, the 1.5 million people who we always forget who are in hospice and palliative care, the 50 million people who will have a surgery every year, and the innumerable numbers of people that will have chronic pain from a various injury or whatever. This bill is basically for them. And I also want to send a thank you out before I start to District Attorney James Buffetti. Our conversations together made this bill a lot better than it started out, and I really appreciate his input on this. Throughout my time, one of the goals that I've had in life is to create a public policy that balances the needs of people in pain with those with addiction. In 1998, I initiated the first state opioid prescribing rules in the state, one of the first in the country. It was an exciting process. Our goal was to create this balance. I'm always amazed at our ability to miss the sweet spot. It's just absolutely incredible. And we missed it with that, although I think what we did was right. But as you know, an opioid crisis happened and a variety of public policies then occurred that basically sent the pendulum the absolute other way. The opioid abatement fund was created as part of that. I'm not going to get into why we have a crisis or why anybody was blamed for that, but my observation is that was functionally the redistribution of tens of millions of hundreds of millions of billions actually dollars from people in pain to people with addiction with no attempt to find the sweet spot in between. The results have been disastrous. In the handout that I gave you, there's a graph that this was a survey of people in pain to find out how they'd been adversely affected by all these public policy measures. It's on page 2. I don't want to go into that in any detail, but I do want to tell you this, and this is why this bill is so important. 85% of people feel that their care has been compromised. Many people feel that they've been abandoned by their primary care doctors or whoever because they feel so much pressure to not care for them anymore. End-of-life care is not immune, which is really sad that people are dying unnecessarily in pain because their doctors are afraid to provide for them. And we can, if you have questions, I'll be happy to share examples. The suicide rate in this population has become a real problem. We actually have a suicide watch that we have with the various organizations I'm involved in. And it's really sad that people, because they're being denied access to a treatment that worked very well for them for a long time, are now going to the street to get their medications or committing suicide. There's a picture on page 2 of a guy named Doug Hale, and I do want to tell his story. Doug Hale was a gentleman that I was asked to review his records for his estate in preparation for a proposed malpractice suit against his doctor. I reviewed 2,500 pages of documents. His suicide note was public, so I can share this information. Anyways, he had various chronic pain problems for over 20 years, was on methadone maintenance therapy for a long period of time, was doing fine. Apparently, because of the public policy changes, people felt that, well, this wasn't such a good idea. And the doctor who was caring for him was have immense pressure put on him to stop this guy's prescribing. Eventually, out of pressure, and he did. And they sent him to a detox place for a 6-day detox from 20 years of methadone maintenance. He came home, said he couldn't take it anymore, took a gun right under the chin, shot himself, and died. It was tragic and it was horrible, but I think his suicide note needs to have a legacy. And that's why things like what we're trying to accomplish today are really important. What I'm proposing with this bill is that these funds actually be used not just for people with addiction, but people who have been adversely affected by the process of creating these funds so that they can have access to them as well. Let me give you an example. So when the opioid abatement suit started, I was advised very early on, because of my role in creating public policy, to not come out publicly and say what I did. And the reason why was they said they will haul you into court at $30,000 a subpoena and they will ruin your life. And they said, and I know that happened for a fact. So what happened was they were doing this to anybody that received any money from any of these pharmaceutical companies. They were hauled into court, and we're talking about nonprofit organizations that function on fumes. And these are the organizations that were supporting people in pain. There were professional organizations like the American Pain Society, the Academy of Integrative Pain Management, and I'm trying to blank on the third one, that no longer exist. They went bankrupt because they couldn't handle these costs. They were basically advocating for the rights of these people. There was a thing called the Consumer Pain Advocacy Task Force, which was a consolidation of 15 groups that advocate for the rights of people in pain. Patient-run, patient-directed. I was involved very much with a thing called the Center for Practical Bioethics in Kansas City, which basically created the hospice and palliative care model we have in the United States now. 7 out of those 15 organizations no longer exist because of being hauled into court. And so there's nobody really there left to advocate for these people. And that's a real problem. And so that's kind of why I'm feeling like, well, the process created a problem. The process should solve the problem. And that's what I'm recommending here. RSA 126A86, which specifies the duties of the Opioid Abatement Commission, lists 17 things those funds can be used for. They were arbitrarily dragged out of a thing called the settlement fund. When I spoke to you last time about prior authorization reform, I put up a 800-page federal document. This one was only 500 pages, but only 14 pages are relevant. But they list what these funds can be used for, and I was led to believe that they could only be used for addiction, opioid use disorder. When we looked through them, I'm also the vice chair of the Opioid Abatement Commission. We actually looked through what those could be used for, and they could be used for what I'm asking for in 18 and 19, which are evidence-based things. The first one's the one I'm most excited about. Number 18 on page 3 would create a novel set of programs that deal with what we're calling opioid refugees, people that were being cared for very well, that suddenly, for whatever reason, have no access to care. And the reason I created this model of medication-assisted type therapy programs was that 20 years ago, 40% of the people in methadone maintenance programs were there to treat pain, not addiction. They no longer can go there. And I thought, well, this would be a great way for us to deal with these people until they can find access to care. And I will tell you, this is a national problem. We get calls every day at the United States Pain Foundation on how do we deal with this issue. The second thing you've already dealt with last year, we presented HB 66, which you passed, thank you, which you were involved with, Senator Prentice, thank you, to create integrative models of care for managing pain. We know that when people communicate together, when they work together as a group, the outcomes are a lot better. So what number 19 would add would be that these funds could be used to create novel programs, such as the pilot program that we're creating to find opioid-sparing ways of better dealing with pain than we deal with now. This bill passed 20-0 in our committee by consensus. It has evidence base, it has unanimous support, and what I'm so excited about is that because of these two thoughts, recommendations, we actually created a priorities group in our Opioid Abatement Commission, that these are now part of our priority list. So do we need the bill? Yes. And the reason why is this is a 20-year process. I love the people on our commission right now. They're really wonderful people. The problem is I don't know who's going to be on that commission in 5 years or 10 years or 15 years, and I think it's important that we establish these as permanent priorities for that group, and that's why the bill's important. And I'm happy to take questions.
Thank you, Representative. Any questions? Senator Prentice, hold on. Can we not block the door? No, it's Thank you.
It's a dual role for you, chair of the committee and fire marshal. Yes, and mom. Is it okay if I what is happening? I don't have a question, but I have something I want to say. Is that all right? Representative Nagel, just in sharing this story. Excuse me. What? Would you believe? I know that I had something to say. I've long why I was not so I was happy to be involved with the study committee, and really Senator Chandler pulled the weight on that. But one of the reasons I had agreed was because of some of the work that I've done specifically as a deputy medical examiner. And I have one particular case where there was a gentleman who his apartment was just absolutely littered with empty alcohol containers, like bottles and bottles and bottles. And I was trying to figure out what was going on, because that's your job, what's going on with him. That's why you go out. And I found some empty, very old pill bottles for an opioid. And to make a long story short, as I tracked this through, this was a guy who had chronic pain, who was unable, like, it's that balance. And I hear you. He was unable to get access to continued treatment. He wanted to continue to work. So he was doing that, and he was purchasing his medication. He was using alcohol, and he was purchasing his medications off the street. And one of the pills that he took had something in it that killed him while he was getting ready for work, drinking his coffee. And it sticks in my mind all the time.
It's sad for me in my world, because I hear these stories every day, hundreds of them. And it's like you feel so impotent to do something about it. To me, this is doing something about it. I had an 83-year-old lady come in to see me once who was not being prescribed. All she wanted was like one Vicodin a day. And she had, all the stuff that people get when they're older, and that I'll never get, I'm sure. But she looked at me right in the eye and said, "My doctors won't prescribe this for me." And I said, "You know what? I'm 83 years old. I don't care. I'm going to just go to the street and I will buy it there." And she said that before fentanyl became an issue and all the other additives and things like that. So it wasn't maybe as dangerous then as it is now. But when I was on the governor's task force on this issue, we got a really wonderful lecture from somebody from the DEA about how the cartels work, how they create pipelines, how they create drugs, how they put additives in those drugs, and how all that stuff is on our street in New Hampshire. And that puts these people at amazing risk when we deny them care, because if they go there, we had 2 people that died of fentanyl overdoses because they thought they were getting OxyContin. And they were husband and wife. I mean, I could go on. I mean, we could be here for days, and I don't want to take up all your time on it, but it's thanks for listening. I appreciate it.
Representative, I have a question. When you were talking about that gentleman that's in your testimony, who was pressuring him to take him off the meds?
Without being too specific, because I don't want to say too much, but so the primary care doctor manages care for a really long period of time, and they had a wonderful relationship. The next bill we're going to talk about is continuity of care, but he had continuity, which is awesome. For people with complex disabilities, that's important. But a lot of his problems were specialized. So he was seeing a neurologist. And they were all at a major medical center. He lived in Vermont, right on the New Hampshire border. They were in a New Hampshire medical center. I won't mention the name, but the doctors there, it's a long story that I've been involved with for a very long period of time, but there was a study published out of that center that suggested something very different than what the center decided to use that bill for, but they were starting to cut people off on their opioids. And this gentleman, as being one of their patients, they were strongly putting pressure on him, saying, well, he doesn't really need these meds and he should be taken off. There is a responsible way to do that. But not a 6-day detox. Within the gentleman's own practice, he started getting a lot of pressure from the other providers who were covering for him, because, this was like subsequent to like 2016. And I don't know if you recall, but like the peak of the opioid prescription part of it, it peaked in 2012 and came down. there was immense pressure on doctors to stop prescribing. And you know, we as doctors, which is another point with the next bill, don't work independently anymore. We work in groups. So you kind of have to do what you're told. So the big guys and then the little guys are both putting immense pressure on him to cut this guy off. And I'm not going to say his record was perfectly clean. There were some red flags, but not enough that I would ever personally cut him off, and certainly not in 6 days from methadone. That was, I'm not going to say what that is, but what I felt as I read through the documents was that it wasn't the doctor, because I've been in his shoes. And if you ever read my book, you'll know the first chapter is all about me being in that guy's shoes. So I felt for him, and that's why I couldn't support the lawsuit. Was I thought I didn't know who they should go after in the entire medical industrial complex. I mean, it was a whole chain of events and a whole chain of people that led to that. So is it right to just blame one guy who really cared for him for 20 years? And if you read his notes, you could see the torture he was going through in making these decisions. It was really hard. I don't have a short answer for anything, sorry.
Senator Bradley.
Yeah, thank you. I always think that, obviously painkillers were way overprescribed going up to that time frame of 2016. But having dealt with family members and constituents also that have experienced excruciating pain, I also felt that the overreaction as lawyers started writing policies about how doctors should prescribe was an overreaction too. So this is more of a question, not so much about this bill or the next bill, but do you think that in New Hampshire, at least, the legal status of experts, physicians who manage pain has been brought back into balance so that there's not the same fear of overprescribing?
Not at all. And
All right, so then is this an opportunity to do more?
Yes.
Should it be?
Yes.
Then what's here today?
So, to me, what I'm trying to deal with is the remnants of this, what I consider a public policy disaster. I have a lecture that I give called The Art of Creating Two Public Health Crises Out of One, which is basically what you just outlined, but it's dealing with the ramifications of all that. So you have now ostracized an entire group of people. And I will give you an example. A friend of mine he's God's gift to mankind. I mean, he ran a pain care practice for a long time, a non-procedural one. You make your money in pain management by doing procedures. You don't make it by prescribing. He had no procedures. He wasn't ringing in the bucks, because we have epidemics of pills and procedures, I think. But anyways, he took care of hundreds of patients. Well, people when they're 70, last I checked, retire. So he turned 70 and he decided to retire. And he had been in private practice most of his career, was employed by one of the hospitals in the area at the end of his career. And they basically just summarily, that's a word, right, discharged every one of his patients. We're talking over a couple hundred patients, and gave him 1 month to find a new doctor. I mean, what I'm proposing with that MAT type program that Attorney Buffetti and I kind of hashed out was, this at least give them a temporary home so that they can have time to find somebody. When I was forced to close my practice, and again, that was a group decision, it wasn't a legal decision, that was like the hardest thing that anybody's ever made me do in my life. It angered me, I almost used a different word, angered me so much I wrote a 900-page manuscript on it that turned into a 350-page book after the editors got a hold of it. But, it's just like, it's just torture to see what happens to these people. And this bill is an attempt to at least try to give them something out of these $300 million we're going to get from this. And you and I met a long time ago about the acupuncture thing. I think it's a natural travesty that we give people pills and procedures, but we don't give them access to all this other stuff. And we certainly don't do it in an integrative manner. We know in complex disability that the best care is integrative multidisciplinary care. So why don't we fund that? Why don't we do that? And HB 66 is an opportunity to try to do that. So these are two great things that could come out of this. And I've talked to people on opioid abatement commissions nationally, and everybody thinks this is what this money should be used for. This is harm reduction. This is prevention. And this is good health care. And this is an opportunity for us to make a big statement, not just here, but nationally. Because when I go to another state and say, this is what we're doing in New Hampshire, you do it too. So this is like a big opportunity. Thanks for like prompting me on that.
Any other questions from the committee? Seeing none. Thank you, Representative.
Thank you. Thanks for the opportunity. I appreciate it.
I see that Laura McIntyre from Granite State House is in support but not speaking. Is there anyone here that would like to speak on House Bill 1318? With that, I will close the hearing and immediately open the hearing on House Bill 1604.
You get stuck with
Welcome
me
back.
again. I have a third bill. You want to do that one while we're here?
No, thank you.
So
No,
I don't
thank
know.
you, as
I don't
my
know if I should
granddaughter said.
specify this, but one of you whose name I won't mention, who I'm actually looking at right now, taught me that the best way to pass legislation is to sit down and talk with everybody beforehand. So I really appreciate that lesson because I think it made all these bills a lot better than they started out because I'm not that good at writing legislation. Anyways, you don't need to know who I am because I already told you. What I would draw your attention to in my handout as we start is on page 2 in the middle, there in italics and bold print, there's a quote from Dr. Eric Topol, and he said everything that I wanted to say. Just so you know who he is, he's probably one of the most famous information technology people in healthcare. He's a cardiologist. He's very much a proponent of the electronic record in theory, but not in practice. And when I found this quote, he said everything I wanted to say, so I'm not sure I need to say anything more, but I guess I should say why I brought this up. So when you write a book, the first thing you get to do is you go on a book tour and you get to promote. To me, it was my ideas, not the book, because I certainly didn't make any money on it, but it gave me an opportunity to go all over the country. And in my book, there was a small section on the effects of the computer and the electronic record and how we care for patients. I have this weird idea that patients actually come to see me to deal with a problem. They don't come to me to watch me peck at a computer and put in data. They want care from me. And so I just felt that it was important when I went on these talks to start saying something, but I was really scared because I was living in this fantasy world that I thought primary care doctors actually liked the electronic records. So one of my sessions, I got up there and I said what I thought. I said, I think the electronic record is horrible. I think it should be thrown into the ocean and never be brought back. And I thought they were going to start hurling rotten tomatoes at me. They did not. They gave me a standing ovation. And I thought, this is great. All I have to do is say something and I get a standing ovation. This is really wonderful. So I keep doing it now everywhere I go so I can get people to stand and make me think I'm more important than I am. So that's kind of exciting. But that's how this process started. You know, I felt like greatly empowered, and it led to a national discussion on like, well, you know, not just from primary care doctors, but from patients and miscellaneous other people. And that's what kind of got me going on this. And so I do want to say that I want to thank a lot of people for helping bring this bill forward because it wasn't that good when we started. The folks from HHS are going to suggest recommendations to make changes. I like all their recommendations, so I would listen to them. That was a great discussion. You know, New Hampshire Medical Society, the New Hampshire Hospital Association thought I was nuts when we started this, but when we sat down and talked about why, all of a sudden they thought it was a great idea. So they're here to support me too, which I think is great. Anyways, with that as a background, the most important things that you and your committee do and what I and my committee do across the hall is whatever we do is do not do anything that interferes with the doctor-patient relationship. Right now, there are so many people in that exam room, I have absolutely no idea who I'm treating anymore. And the patients feel that. And the cost of doing that is immense, that because of that, I don't know if I'm buffing a bottom line or taking care of a patient, because I'm told I have to raise revenue to cover the costs of my prior authorizations and my electronic record, because it costs about $1 million to put in an electronic record. the way, oh shoot, that's my phone. Whenever I canter, I always tell everybody to turn their phones off. Anyways, it'll stop. It's probably President Biden asking for my.
It's a nice ringtone.
Yeah.
You
should
listen to mine.
It's generic. The other thing I'm going to say, and I will go to my death and my grave saying this, but I've been practicing for 35 years. The worst thing we have done in healthcare is to kill private practice. When I started, private practice was 80% of the market. Now, real private practice is about 15% of the market. I work at the University of Rochester School of Healthcare Economics. Believe it or not, I'm an economist, and it's not, I'm a doctor too, but the gentleman that runs that program said that within the next 5 to 10 years, private practice will no longer exist, that there will be 3 to 5 providers of insurance and 3 to 5 providers of healthcare in the entire country. I belong to Concord Orthopedics. We're a big group. This is very public. We just merged with 4 other groups. And the reason we did it is because there's an insurer that's migrating into the state that won't talk to us. So in order to be able to have any kind of negotiating clout with them, we had to merge with 4 other groups. And that's the way healthcare is going. I think it's a disaster. And so what I wanted to do with this bill was to try to, and the Pryor Roth bill, their bookends, is to try to figure out, well, how can we empower private practice by making them cost effective and allow them the mission that they've always served really well. And so that's where this came from. When the electronic record was originally envisioned by George Bush in his 2004 inaugural address, he basically looked at it in the way I kind of did too. He said he implied that EMR could be used to facilitate communication providers and improve healthcare. That sounds great, but it's not how it evolved. Over time, CMS got a hold of it. And in 2009, somebody back there told me the name of this, and I forgot it. It was in my original manuscript. But anyways, they functionally created a thing called meaningful use. Meaningful use means that it was basically created by public policy gurus that looked at us as their labor force, and that our job was to collect data for them. And so whenever you're asked, do you feel safe in your house? I always say no, because my wife's, she's a rough lady, but that's one of the questions you get asked. And I'm also been involved in the creation of the National Pain Strategy. And when we were looking for data to prove our points, they wanted to look at meaningful use to add even more questions. And I remember raising my hand and I saying, do any of you practice in private practice? Nobody said yes. And I said, do you realize that the more questions you put in there, the less time I have with my patient, the more time it costs me, the even less time I get with them, because I have to see more patients per unit time to make enough money to cover the cost of what you're asking me to do. And they didn't even realize that. So we stopped that direction. That was a really good thing, I thought. But anyways, the other thing that's really sad and weird is that we started getting hit on by people telling us that if we designed our record in a certain way, that we could generate more revenue. So by putting this bullet, that bullet, this bullet, this bullet, that bullet in certain ways, you could maximize your billing. So all of a sudden, the electronic record became a data collection thing, and it became a way to maximize my billing. If you see the records I get from other providers, I have no clue why the patient's there to see me, why they've sent the patient to me. There's no record information in there that's even like remotely communicative, and that's a problem. And basically what all this has led to is a dramatic increase in the cost of providing health care. It's led to fragmented care, and we could explain that in detail if you want, but fragmented care, in my opinion, is bad care. The other thing that's scary is if you look at physician burnout, provider burnout, the electronic record is listed as the #1 reason for physician burnout. So that does affect our labor shortages in healthcare and things like that. I also personally think this is my other really big concern, Senator Bradley, that, I really want to see alternative providers become part of the mainstream of providing healthcare. I think it's really important. So I'm about to go to Wisconsin to give a talk at the American Academy of Medical Acupuncture, and every year they're going to tell me they want to be part of the healthcare insurance network, and I'll say, why? And they say, I said, do you really want to have to deal with prior authorizations? Do you want to fork out $500,000 to $1 million as an upfront cost on electronic record? And they said no. And then I say, well, do you want to, so why do you want to do this? And they say, it's because we want access to lower income people. And I think that's honorable, but I think they're crazy personally. But what I would like to do is give them an opportunity at low cost to be part of the healthcare network. And I want to be able to bring back private practice, because I think it's really important. And I would like to see that 15% number become something a lot bigger. And so that was the whole point of this bill. The bill has a couple parts. There's a definition of EMR. I'm a stickler. We have to have definitions to describe what we're talking about. The bill says you cannot require a health care provider to use an electronic record. That got misinterpreted in our committee. I really think the electronic record has potential of a lot of value. I don't want to get rid of it. I just want to make it go back to what its fundamentals were. Right now, Medicare can withhold 15% of my fee if I don't participate with meaningful use. I think that's crazy, and I don't want that to happen anymore. And I don't want anybody to require a specific format of EMR. My EMR that I use at work looks exactly like what I used 30 years ago, and it communicates what I'm thinking really well. The current models that a lot of private practices use or primary cares use, they don't do that. They're just data to collect billing and collect numbers. So that's why I thought that was important. And then there's a listing of what information can be required or whatever. One of my concerns or problems with this bill is that it only applies to the wonderful people sitting behind me who I really like and we've really gotten to know very well. And I think they're great people. We've had great conversations. It does not apply to Medicare, Medicaid, federal insurances, things like that. So why is this bill important? Two reasons. Number one is insanity is doing the same thing over and over again, expecting a different result. What we've accomplished isn't good. We can start a spark here in New Hampshire that I think can go nationally. I do have a national audience. I do talk to people all over the country. I do know people at CMS. We do have the ability to start something here, but that's not the other reason. We have to anticipate what the healthcare market's going to look like in this state in a couple of years. We need to set clear rules with large providers in the future of what you can and cannot require us to do. And the commercial insurance industry in this state is going to look a lot different in 5 to 10 years if things continue the way they are. And I think we need to anticipate that. And that was the other reason this bill was important to me. I'm done.
Thank you.
That was more than 5 minutes, right?
Yeah.
Sorry.
It's okay. Senator Prentice?
Thank you, Chair Berzel. Representative Nagel, thanks for taking my question. I'm just looking for clarification here. So a healthcare provider could still use an EMR if they so choose. But so it's like an either or, and it's the relationship to the payers.
So just to give you an example, one of my friends is an acupuncturist. She has an awesome EMR that I would use in a heartbeat that costs her next to nothing. She's in private practice. It does everything what she wants it to do, collects the data she wants it to do. It allows her to do her billing. It allows her to do everything. The problem is it doesn't communicate meaningful. Well, it's managing interoperability. We had to use a new word. So it doesn't, it won't work with federal or insurers directly, but for her world it works perfect, and it's incredibly inexpensive. And I mean, if in a heartbeat, if I could, I'd use that.
Thank you.
Any other questions from the committee?
So I'm sure we're going to hear from the carriers. And obviously on line 9, there is no conflict with federal law, so that totally eliminates VA, Medicaid, Medicare. But are there, I guess my question is, I don't see that there would be a problem with C and D in your legislation, but A and B, withholding of a fee or requiring the in other words, making it optional to use an EMR. So my question is, would it be a better place to start with just C and D?
That is a really interesting question because I've thought a lot about it, but this is who I'm trying to protect. Is I really think, as I said earlier, and I don't know how to write this better, and I would be happy to put that in your seat to do that. But I'm trying to protect chiropractors, acupuncturists, massage therapists, people like that when they migrate into the more general mainstream, which I really think we really need to do.
And having sponsored the acupuncture licensure law and chiropractic and some of the other, back in the day when I owned a natural food store,
I remember
totally agree
that.
with you.
Yeah. I'm just trying to figure out how to write that to say that. I mean, as a doctor, for me to not have an EMR is crazy. I mean, it's just a question of the format of it. And
Is there a way of, sorry to be interrupting, but
No,
is
you're
there a
fine.
way to incorporate some of these other practices that are more non-traditional acupuncture, chiropractor without, it applying maybe as a pilot program for those practitioners
Interesting.
on A and B?
That's an interesting thought because it might incorporate with the pilot that we're doing on, I don't know I can't remember what number it is this year, but HB 66 from last year, because that is what we're doing. Is trying to figure out how to include them into a real model. So that's an interesting idea. I'm glad I came here today. Does that answer your question?
Well, I don't know. Pat Tilley's going to give us all the answers, so.
She's next.
No, she is. And we talked beforehand, and I really want to defer a lot to them because I think they said some really smart things. And I actually, everything that they're going to recommend to you, I think is a good idea. So I don't want to keep you in suspense.
Senator Prentice.
Thank you, Chair Bertzel. Senator Bradley, agree on A, agree on C, and no, I understand what you're saying about A and B, and then keeping C and D in. But if we were to move into a pilot stage, I would want to keep B in because I don't think payment should be withheld if we were going to try this out. I mean, I have a concern about payment being withheld, so I wonder if there's a give and take on that.
Well, I've been thinking out loud.
Yeah. Well,
More
I
than
am,
anything,
yeah.
so, I mean, that's more for probably an exec session and a work session, but
okay. I just,
that's,
If I could say, I'm personally have always found it insulting that they feel they can withhold my fee because I choose to not do something in a certain way. B is really important to me. That's just my 2 cents on it.
Thank you, Representative. Any more questions? Seeing none. Thank you. Trish Tilley. I know you got to get to G and C after this. Welcome.
Good morning. Again, my name is Trish Tilley. Patricia Tilley. I'm an associate commissioner at DHHS. Always happy to be here. Thank you, Madam Chair. So good morning. We have a few questions about the scope of 1604 and a possible solution to at least one of those loose ends. As Representative Nagel noted, we connected the hall, and I think we have a plan. The department, separate to the conversation that you've all just engaged in, we want to ensure that the intent is solely focused on the EMR, the electronic medical record, and not eliminating requirements for the secure transfer of information. There are some very technical differences between an electronic medical record and an electronic health record. I will spare you those differences right now in the interest of time, but I have very smart people behind me in case you actually want to dig in and sort of go through the weeds on that. But what I think we all agree on is that providers need to exchange patient data securely seamlessly, and efficiency and interoperability is the way to get there. And that's the focus of our concerns today. At the state level, we've got several statutory and rule-based requirements for the electronic submission of medical information to the Department of Health and Human Services. These requirements do not specify that our provider uses an EMR or an EHR, but it does require electronic submission and connections using something called an HL7. HL7 is a widely used messaging set of standards. I like to think of it as like a giant pneumatic tube, like when you go to the bank office, it gets stuff there, you know, when you go through the drive-through, but it is an electronic configuration that provides the guidelines for storing and sharing data securely. This ensures that that the data can be integrated across systems, and it reduces significant administrative burden on both sides, both the provider side and on the receiver. So the department receives a variety of these records. We get them through Medicaid, we get them through public health programs, we get them through child protection, we get them in adult protection. Additionally, we've got some statutes about reporting data specifically within these HL7 pathways for things like our cancer registry, our hospital discharge data, and reporting of communicable diseases. So while EHRs can improve the quality and efficiency of care, at times, I think we've heard times when it doesn't. An EHR or an EMR is not specifically needed to effectuate those data exchanges, but we do want to make sure that the intent allows for the secure transfer that does often have to happen electronically. We're less interested in what that person's EMR looks like, specifying what it is. It's really about the connectivity between the two. So to solve this problem, we would suggest for your consideration is adding some language that basically says, notwithstanding any other provision of state law, state or other jurisdiction law. That will cover us. That will say you still got to get the information where it needs to go securely, easily. It does not say you have to use XY EMR system. So we can work with Representative Nagel to the other piece is sort of differentiating EMR, EHR. We can do that offline. And we want to make sure that we have that notwithstanding state statute. And I think that would keep 1604 in alignment with our existing authorities and will ensure that there's secure exchange. I think we're also open to working with the committee and with the sponsor on any other things that you may be thinking. So that's it for me.
Questions from the committee? I actually do have a question. Excuse me. So some of the less expensive EMRs or EHRs that Representative Nagel was talking about, are they? Do you know if they're capable of working
Yes.
with the secure exchange?
Yes. Yes, they are. They can be. I mean, you have to put that in place. And for someone like a naturopathic or an acupuncturist, they're not sending the Department of Health and Human Service cancer registry information or, information about hospital discharge. So some of it's moot in some of those specialty providers. This is really for like rural healthcare providers or others that may be like a doc with a shingle where they may have to report a communicable disease. So, I think that's a two-part answer is yes, there's capability and not everybody has to have it. But if you are a general provider, traditional sort of medical provider, this probably should be in your wheelhouse is to figure out a way to electronically submit.
And they typically, if a chiropractor or a rural doctor is looking at doing the EMR type, they're going to have to do that communication piece anyway.
Likely. So I can give you an example. We've been working on everyone's favorite thing, which is our New Hampshire Immunization Information System, which is optional, just putting that out there. We're not having that conversation today. But for those that were engaged in that, we worked very long with a number of those smaller providers to make sure that they had that HL7 connection so that they could send the information to the department. We were able to provide some technical assistance and make sure that that could happen.
Thank you. Any questions from the committee? No? Seeing none.
Thank
Have
you.
fun at GNC.
Always a fun day at GNC.
All right. Peter Bragdon. Welcome back.
Thank you, Madam Chair, members of the committee. I earlier today was at the GNC breakfast meeting. I'm here and then I'm heading up to the GNC meeting. So yeah, a fun-filled day for GNC related stuff. For the record, Peter Bragdon, Senior Policy Advisor at Preddy Strategies here in Concord, here today representing Harvard Pilgrim Healthcare, New Hampshire's nonprofit health insurance provider. And I'm in the unenviable position of being in opposition to a bill that Representative Nagel has sponsored, because I've certainly enjoyed working with him on various issues, from chronic pain to the prior authorization. He just brings a great perspective on things that is often missing. But we are here today in opposition to HB 1604, and would hope that you find it inexpedient to legislate, or perhaps it just needs more work. And personally, from a personal perspective, just me as Peter Bragdon, I understand some of his frustration as well. As some of you know, my background's in software development. I graduated with a degree in computer science, helped to start a company out of college that I grew to the Inc. 500 list of fastest growing companies in the country. Numerous awards in our industry for the software that we produced. And I've read about the difficulties faced by providers from the widespread and arguably coerced adoption of electronic medical records. Sometimes, and often it seems, without input from the clinicians themselves, the boots on the ground, who are actually going to be using the system the most and providing it. So I understand where that frustration comes from. That being said, we believe, and I'm going to switch glasses here. I don't know if you guys have experienced this, but it's like I need one set of glasses to read, another set of glasses to do everything else. I'm not liking that at all. That being said, we believe the bill is, to use a phrase that I learned in my first week as a freshman state representative way back when Jeb Bradley was a state representative as well, we believe the bill is a solution in search of a problem. And I say that because the bill seeks to ban health insurance carriers from requiring providers to use electronic medical records. However, Harvard Pilgrim Healthcare does not require providers to use electronic medical records, nor do we plan to require them to use electronic medical records. We're not aware of other health insurance carriers in New Hampshire that require the use of electronic medical records. We don't require that for those who do use them. We don't require specific systems to be used. We don't require specific data to be entered. All of these are items that are addressed by the bills, but we don't require them. I will say that though we don't require providers to use electronic medical records, we support and encourage the use of them because we do believe the best care for our members occurs when information can be exchanged easily back and forth, and electronic medical records facilitate that. They help us with coordination of care and care management. They help us detect situations where patients have multiple prescriptions for a drug, either accidentally or on purpose. There's a lot of areas where they can help us. And from a personal level, EMRs are the background of what allow me to sit in my living room and review through a portal my personal medical records or those of my elderly mother. So there's a lot of benefits to electronic medical records. And for those reasons, we support it. However, we do understand that some providers may be in rural areas where the IT infrastructure is not robust. We understand that some providers may be smaller, independent practices that don't have the financial capacity. And certainly there's been a lot of consolidation in the provider world. And I don't think it's entirely the fault of electronic medical records. But we understand that the financial resources may not be there. And we understand that some providers offer specialty services whose information may not be quite as critical as that in the examples above. For instance, chiropractors or acupuncturists, who we've talked about before, right? They're not going to be prescribing drugs. It's not going to be as critical. So for all those reasons, we don't require the use of electronic medical records, nor do we have plans to require them. This bill seems to me to be a response to what is happening at the federal level, namely CMS, who seems to be moving in the direction of requiring Medicare and Medicaid providers to use electronic medical records. Even now, as I think Dr. Nagel pointed out, they can withhold a portion of a provider's fees for not using electronic medical records. I believe it's 15%. Obviously, our fees are in a contract with the providers. We can't just withhold payment. It's a contractual obligation, whereas CMS can pretty much tell people to do whatever they want them to do. So I guess in short, passing this bill will not change any of that. CMS is still going to be doing the things that CMS is doing that some would arguably is coercing people into using electronic medical records, despite many situations where it is not the appropriate thing to do. But we don't think that this bill is necessary from the point of view it's not going to stop what is happening outside of the realm of state carriers. That being said, I'd be happy to answer any questions you might have.
Any questions from the committee? Senator Brownlee?
So what about the thought for those alternative practitioners like acupuncture, chiropractor, naturopath, allowing this as a pilot basis?
Allowing what as a pilot basis?
No mandatory EMR.
Yeah, well, again, thank you for the question.
I mean, and I get the fact that you don't do it.
Right,
But
right.
I
And
think the sponsor is saying, probably in response to CMS, that New Hampshire should put a stake in the ground.
yeah, I understand. Thank you for the question. And right, it's something that would have no effect on us because it's not something we do anyways. It's just a matter of, do you want to pass laws for everything that might happen? You know, we don't have a law that says dogs can't drive cars. That just isn't going to happen. You can have a lot of laws out there to keep track of that really have no effect. So, first thing that came to mind.
Well, with 300 Senate bills.
Any other questions? And my dog can drive a car.
Whoa! Wow.
She's smart.
There should be a law against that. Thank you.
Thank you. Sabrina?
Thank you, Chair Birdsell and members of the committee. I'm Sabrina Dunlap. I'm Director of Government Relations for Anthem. I'm going to change my testimony on the fly because I don't want to repeat what Peter said, but I basically echo everything, including the fact that I too have worked with Representative Nagel on a number of issues and really appreciate his perspective. And we have a lot of spirited, interesting discussions about healthcare. So I'm also not happy to be sitting here opposing this bill, but I do agree it seems to be a solution in search of a problem. And it also feels a little bit like, you know, in terms of going, not going after, but in terms of this applying to commercial insurance, it's sort of barking up the wrong tree. As Peter said, we also do not require the use of EMR or EHR. And, you know, that being said, I would say we also appreciate sort of the move towards digital tools and EMR and EHR. And I think that train has left the station in terms of the federal government. Obviously, CMS is pushing this, has been for many, many years. And we do see the benefits of, you know, digital tools. Things just move faster. And providers can still use paper. It does take longer. It's less efficient. There are other issues with paper. I will also say in a past professional life, I worked at an EHR company. And so I appreciate the challenges with them, but also the many benefits of them. And again, they're not perfect, but I think that is certainly the direction healthcare has moved and continues to move. And I do worry a little bit about some of the elements of this bill. Again, providers are not required to use EMR, but when they do use them, I think some of these elements might sort of meddle with how we sort of manage the use of digital tools and electronic medical records, specifically the prohibition on requiring certain information. I think it could pose some logistical challenges. If a provider is going to use an EMR or an EHR, that we have to make sure our systems can work together and speak to each other. I do worry this might sort of interfere with that. So anyway, I'm hoping you will vote in expedient to legislate, or again, you know, perhaps a study and spend a little bit more time on figuring out how we can try to solve some of the pain points in this space. So thank you.
Any questions from the committee? Seeing none, thank you. Heidi? Welcome.
Good morning. Good morning, Madam Chair, members of the committee. For the record, my name is Heidi Kroll. I work at Gallagher, Callahan and Gartrell, and I represent AHIP. I won't repeat the comments that Ms. Dunlap and Mr. Bragdon have offered. AHIP agrees with everything that they've said. The one thing that I did want to offer to the conversation is simply to the extent, so we would support either an ITL or interim study, but to the extent the committee decides that they want to move forward with something, I think it's important to consider where in statute we put this requirement. You're talking about placing a requirement on the fully insured health carriers. And so we have statutes, we have insurance statutes for that. And so this is proposed to be placed as a new section in RSA 332. I did a quick search on electronic medical records. It only popped up 4 times in our statute, and it was appearing in some of the pharmacy statutes, and that's just with respect to the pharmacist using electronic medical records to communicate with the providers, those who are writing the prescriptions, and so it stays as part of the patient record. But anyway, I just wanted to offer that there may be a more appropriate place in the statute, such as in the insurance statutes, to place any sort of requirements that you might decide to move forward with if you're placing those on the health insurance carriers. That's my only comment. I'm happy to try to answer questions.
Any questions? I do have a question. And I probably should have brought it up to Sabrina, but my question is, don't you have concerns? And I think this is an issue with CMS more than it is with New Hampshire, but CMS, if I have this wrong, feel free to correct me. Is CMS requiring, if a chiropractor or acupuncture wants to get into this, wants to have access to electronic records, they're purchasing what they can afford. But if CMS doesn't like it, then they can withhold the payment. Why are we dictating? Why is even CMS dictating what an office thinks that they can afford?
I'm sorry, I don't have an insight really into kind of, why CMS thinks they have the authority to do that. I do know that, consistent with the testimony from others, CMS is moving, has been moving in the direction of, electronic systems and interoperability and communications, even just on the some recent guidance that they've given, rules on prior authorization. There's a big push in there, both on carriers and on providers, to be moving toward electronic prior authorization. We have, electronic, like e-prescribing. There's just a lot in general that's moving in that direction. And so I think, CMS is trying to, I guess I would say, from a 30,000 foot level, they're probably just trying to provide, carrots and sticks, to try to get everybody to be moving in a particular direction. But I'm not a
More
CMS
stick than carrot.
Yeah, I'm not a CMS expert, so I that's about as much as I can offer you.
Senator Prentice?
Thank you, Chair Britzel. Heidi, thank you for taking my question, since you work with all of the carriers. And I could have asked Sabrina this, but it didn't dawn on me until you were speaking. If we were to have a pilot, as was suggested earlier, with maybe some limited criteria, do you think that is something you, that AHIP could talk to the providers about and see if we could get some consensus there?
We're certainly happy, as others have said, we've worked with Representative Nagel on a number of different fronts, and so happy to have that conversation and see where there might be opportunities. Yep.
Okay, thank you.
Any other questions from the committee? Seeing none.
Thank you.
That looks like our last speaker. Is there anyone here that would like to speak on House Bill 1604 but was not given the opportunity? With that, I will close the hearing. And we will not be execing any House bills this week.
Okay.
Don't let us go round and round.
I hate that.